Derneği'nden çok değerli bir katılımcı ile olacak. Bize bugün COVID-19 pandemisinin göçmenlere etkisi, küresel bir krize dair temel perspektifleri sunacak Sayın Charles Agemank. Dilek Aslan Hocam moderatörlük yapacak bu oturumda. Ben sözü çok fazla uzatıp sizleri de sıkmadan Dilek Hocam'ı zaten tanıyoruz ama sizlere kısaca sunup ondan sonra sözü Dilek Hocam'a bırakmak istiyorum. Profesör Doktor Dilek Aslan, Hacettepe Üniversitesi Tıp Fakültesinden 1994 yılında mezun olmuş. Halk sağlığı tıpta uzmanlık eğitimini Hacettepe Üniversitesi Halk Sağlığı Anabilim Dalı'nda 96-2000 yılları arasında tamamlamış. Halk sağlığı uzmanı olarak 2000 yılında çalışmaya başlamış. 2004 yılında beslenme ve gıda bilimleri bilim uzmanı olmuş. 2005 yılında doçent, 2010 yılında profesör unvanı almış Dilek hocamız. Halen toplum beslenmesi, uluslararası sağlık, yaşlı sağlığı gibi halk sağlığının temel alt disiplinlerinde akademik çalışmalarını sürdürmekte. Hekimlik yaşamının önemli bir sorumluluğu olarak kabul ettiği tütün kontrolü çalışmalarında da 20 yılı aşkın bir süredir aktif olarak rol alıyor. Tıpta uzmanlık ve tıpta halk sağlığı uzmanlığı ile ilgili çalışmaları var Dilek hocamızın. Uluslararası birçok yayını, dernek ve meslek örgütlerine üyeliği var. Yeni koronavirüs hastalığı mücadelesiyle ilgili akademik ve toplumsal çalışmalarını görev yaptığı Anabilim Dalı Halk Sağlığı Uzmanları Derneği COVID-19 görev grubu gibi çeşitli platformlarda da sürdürüyor Dilek hocamız. Hasüder COVID-19 görev grubu çalışmaları kapsamında toplum düzeyinde paylaşılan 62 metini bizlerle paylaşıp korona postasında yayınlanmasını sağladı. COVID-19 ile ilgili basılmış veya yayın aşamasında olan birçok çalışması bulunmaktadır Dilek hocamızın. Ben sözü Dilek hocamıza bırakmak istiyorum. Sayın Charles Agemank'ı da tanıtıp oturumu başlatacak. Dilek hocam, söz sizde, iyi bir oturum diliyorum.
Çok teşekkür ediyorum Lütfi Hocam. Değerli katılımcılar, Halk Sağlığı Uzmanları Derneği webinar ekibi tarafından düzenlenen bu akşamki webinar etkinliğimize hoş geldiniz. Bu etkinliğin düzenlenmesinde Hasüder webinar ekibine ve Hasüder yönetimine çok teşekkür ediyorum. Akşamın konuğu çok kıymetli Profesör Doktor Charles Açman. Dr. Açman, I would like to welcome you. It's my great privilege and honor to introduce you to the members of the Turkish Public Health Specialists Association. Tonight, we will have the opportunity to listen to you on the impact of COVID-19 pandemic on migrants from a global perspective. Before giving the microphone to you, I would like to give brief information about your CV, and my introduction will be in Turkish. Değerli katılımcılar, Dr. Charles Açman, Amsterdam Üniversitesi Tıp Fakültesi'nde küresel göç, etnisite ve sağlık profesörü. Dr. Açman doktora derecesini Rotterdam Üniversitesi Erasmus Tıp Merkezi'nden, master ünvanını ise Edinburgh Üniversitesi Tıp Fakültesi'nden aldı. Araştırmaları çok ama özellikle az gelişmiş ve gelişmekte olan ülkelerde kardiyovasküler hastalıklar ve bulaşıcı olmayan hastalıklarda etnik eşitsizlikler konusunda çalışıyor. Doktor Açman'ın son 20 yılda 280 yayınlanmış makaleleri, kitapları var. Uluslararası bilimsel dergilerde editörlükleri var. Avrupa Komisyonu tarafından desteklenen RODAM çalışmasının bugün için yürütücüsü. Konu ise Afrikalı göçmenlerde genetik çevre etkileşiminin diyabet ve şişmanlığa etkisi. Doktor Açman, Avrupa Araştırma Konseyi üyesi, Avrupa Halk Sağlığı Derneği Göçmen ve Etnik Azınlıkların Sağlığı Birimi Başkan Yardımcısı. Yine Doktor Açman'ın Dünya Sağlık Örgütü'nün göçmen sağlığı çalışmalarına katkıları var. Dr. Açman, once again, please accept our sincere thanks for being with us tonight. After your presentation, we will have time to accept questions and comments. I suggest our guests to share their questions and comments in English using the chat box, and maybe have the microphone after your presentation. And Dr. Açman, the mic is yours.
Thank you so much for the great opportunity and also a nice introduction about me. It's truly a pleasure to talk to its distinguished colleagues. And more important, thank you so much, Professor Aslan, for inviting me to give this presentation. So as you've already said, my talk is going to be on the impact of the COVID-19 pandemic on the migrant populations. So first of all, I'm going to actually talk a little bit more about the background, sort of a little bit more about the COVID and put it into the minority and the migrant perspective. As you all know, the COVID-19 was detected in China and Wuhan in late 2019. And since today, as actually I check from the Johns Hopkins website, it's almost, 114 or 115 million infection has been reported so far globally. And with this come with nearly over 2.5 million people have lost their lives to the COVID. Unfortunately, still, the exact source of the COVID is still unknown. Probably many of you saw that, I think about 3 weeks ago, there was a delegation from the WHO for people to travel to Wuhan. But when they went there, they actually now say that they don't even know. Initially, it was thought that it might have happened from the market, but now they are not sure. So they're still ongoing to try to figure it out what is actually going on. In my country, in the Netherlands, where so far with the country, over 1 million people have been actually been infected. And over nearly, I would say, 15,800 people have lost their lives in the Netherlands. Because I'm talking about Turkish, I also actually have a very quick look about what is happening in Turkey. And today's figure actually suggests that about 2.7 million people have also been infected in Turkey. And nearly, 28,700 people have died in Turkey. And if you look at actually the COVID situation, actually it's quite complicated, and it also make it very difficult, and it's very easy for some people to get infected. So if you look at it from here point of view, so once someone sneezes, it spreads, and it can just basically land on anywhere, chairs, doors, and everywhere, and that makes it very, very difficult for people to protect themselves. And for the last few months, we've also been experiencing different variants that is actually coming up. And so far, the major variants that are actually known to be well discussed include the UK variant or the Kent variant, which you now know that is very highly transmissible than the actual or the wild type virus that's originally emerged. There is also the South African variant, which is also shown to be more transmissible than the original type. And now you have also one in the Brazil variant, which actually appears to have more mutations or variants, and is also potentially can increase transmissibility. So clearly that is actually what is actually now. And so far you know that it takes about 14 days to develop the symptoms after the exposure. So the clinical presentations, the spectrum of the illness actually associated with COVID-19 is actually quite broad. And sometimes it ranging from some people actually having no symptoms at all to, in some situation, life-threatening, respiratory failure. And that symptoms typically, arise about 4 to 5 days after the exposure. And sometimes symptoms are mild, actually in about 80% of the cases. And include sometimes fever, fatigue, cough, and sometimes, difficulty with smelling, and then taste problems. So what we know about the factors in relation to COVID-19 is very well acknowledged. And that includes actually old age. In other words, the older people have been particularly affected by it. We also know that those individuals with medical comorbidities have been very badly hit. And this includes, cardiovascular diseases, diabetes, hypertension, chronic lung disease, cancers, chronic kidney disease, obesity, and smoking. And this is a very nice graph from CDC in the US. For instance, if someone has got a hypertension, their risk of being hospitalized is nearly 3 times higher. Obesity 3 times higher, diabetes 3 times higher, chronic kidney disease 4 times higher. And if someone has got the severe obesity, it's up to 5 times, as well as if some people have comorbidities, is also up to 5 times higher. So clearly, the underlying factors is very well discussed. And I think what is also very important, that the COVID has it affects all people from all walks of life. And I think I've just put some examples of about the famous known phases, global phases, such as, Prince Charles from the UK. If you look at the world leader that's been affected, you have Boris Johnson in the UK, up to Macron in France, and many other people globally have been clearly affected by COVID-19. So in that regard, COVID-19 doesn't actually care whether you are famous, you are a king, you are poor, you are rich. It affects all kind of people if they have their hands on you. But what we've also learned over the last few months, though, is that within the populations, it appears that if you are older, as I've mentioned, your risk is very, very high. We know that individuals that are also live in a very deprived areas or people who are poor also actually been very much affected compared to those that are richer. We also know now that if you are a man, your risk is higher than if you are a female. And it also appears that, the minority populations is also been very much affected. And that is actually what is where my talk is actually going to concentrate on this evening. So I'm going to basically talk about the migrants and the minority people in terms of the COVID. So probably many of you have seen that, globally, that, all the major news outlet globally, such as, BBC, like, Times, like, Washington Post, there has been a lot of discussion, and this is purely based on the studies or data coming from the UK and the United States. For instance, we see the BBC saying the coronavirus, Black African death 3 times higher than the white people. And, you see here saying that Black and Asian people 2 to 3 times higher, also in the UK. And then again, here, coronavirus is infecting and killing Black Americans at an alarming high rate. So it has actually attracted tremendous amount of attention globally, showing that the minorities are more affected compared to the host population. And indeed, if you then zoom in and look at the figures, it actually tells a very compelling story. So this is actually CDC, and that showed a number of cases. So here they actually group it in a relative risk. So if you look at the, in terms of the cases, the American Indians or the Alaska Natives are more than 2 times more likely to be infected. The Black was 1.5, almost 1.4, and then the Hispanics is 1.27. In terms of being admitted to the hospitals, is more than 4 times, or around 4 times in all the population except the Asian population. In terms of death or dying from the COVID is also much higher, nearly 3 times in all the groups, except of course the Asian population. So clearly the minorities are more affected, they are more hospitalized, and they are more likely to die compared to the host or the general population in these countries. And one of the very interesting examples in the US, some of the data that's actually shown that, you know, if you actually look at the African Americans, their share of the population is far lower than their share of the COVID. And if you take some states in the US, such as Kansas and Wisconsin, that you see that that is the share of the population. It's just about, you know, under 10. But the share of the COVID is more than 25%. So clearly you see a very huge disparities here. If you actually cross back and come to Europe, also in the UK, where the data has been more available, again, you see here that if you compare the general British population compared to the migrant population, you see that the minority population or the migrant population, almost all have much higher rate. So here you see that this is males, this is men, and you see that this is the basically per 100,000 per population. So this is basically about the British men and women, and you see just, you know, during that time was just less than 10 per 1,000. But look at what is actually happening among the minority populations, you know, particularly you're looking at the mix, the Indian, the Black, and then the Bangladeshi and the Pakistani populations. You see, this is also for younger people and the older people, you see exactly the same patterns. Again, there's also another study that's also done in the UK, which actually UK Biobank. Again, you see the figures coming here that, you know, those people that actually tested for the COVID, this is actually the line coming here is the general population. So you see that in all the groups, the minority population appear to more likely to be infected. You also see here that, you know, those people that are test positive, you see clearly that in all minority groups, even if you adjusted for major important factors, and also, yeah, those people that were being admitted to hospital as well, clearly showing similar data like you see in the, yeah, you see in the US. So the question is, you know, what is then happening in other parts of the world? Unfortunately, you know, only UK and US has been the country that actually were able to produce data very, very rapidly. In many countries, it's still a struggle to get the data. But having said that, there's a lot of effort is being made currently to try to shed light on what is happening in many other countries. And in the Netherlands, where I live, for instance, the data situation is actually also very, very limited. But the Central Bureau of Statistics, we did some very analysis, one of my colleagues did, and it turns out that equally you see that the minorities or the migrant populations are also highly affected. But the problem is that all the data are meshed, so you actually don't know which specific migrant groups are actually being affected here. There is also an issue of actually the infection rate, and more importantly, the prognosis. If people do actually get infected, what is the trajectories? And also, what is the reach and the uptake of the recommended protective measures that are being actually advised across several countries? You know, there is a lot of measures up there to protect ourselves, but how is these measures being followed or being properly followed by different population in these countries? So we were quite lucky that the Dutch, you know, research organization actually approached our team to try give us some money to do some work among the minority population in the Netherlands. So we actually took that advantage to try to produce data among this. So the main aim of that work, actually, which is currently ongoing, was basically to investigate how ethnicity affects the epidemiology of COVID-19 in the Netherlands, and here in terms of infection rate and also in terms of prognosis. And second, also to investigate the reach and uptake of the recommended control measures by the various ethnic groups in the Netherlands. And last not least, also to assess how these measures are actually impacting on the well-being of these different populations. So we have actually designed 4 key work packages. And the work package 1 is actually looking at the epidemiology, sort of infection rates. Basically, our main interest actually was to look at the zero prevalence. In other words, how many people have been exposed to COVID-19 across different ethnic groups. And the work package 2, which I'm leading, also actually looking at the COVID-19 disease outcome, actually the prognosis over time. So my interest here to assess differences in the severity of the COVID-19 infection and also access to treatment and then their determinants. And another work package led by my colleague, Professor Strong, is also looking at the control measures. How is these measures actually being reached all the populations? And 4, more importantly, how do you then use this information that will come out from this work to guide policy and others? So these are basically the work that is currently ongoing. And some of this work actually done by the municipal authorities in Amsterdam. And what you see here is that, again, we look at the standardized rate of hospitalized admission of COVID in the Netherlands. And this was actually between February last year to May. And we see here that if you look at the Dutch population, it's just about 41 people per 100,000. But you look at the minorities, such as the migrant population, Sudanese population, you look at the Moroccan population, you also look at the Turkish population as migrants, and then the Ghanaian migrants. So you clearly see that all the migrant population are more likely to be admitted to the hospital with a COVID compared to the host Dutch population. And you also actually move one step up, as I say, to look at the zero prevalence. So you have a very large study going on currently in Amsterdam. The name is the Helios study. And we've recruited nearly about 25,000 individuals in part of the study. We started back in 2012. So that actually gives us a very good opportunity to sample some of these people to share knowledge about the COVID. So we actually sampled about 2,500 people from this study to give us an idea about the zero prevalence or those people that have been infected with that. So when you actually study these people, you actually could see here, of course, the study was done between June and October 2020. But within that time, when you measure it, you clearly see that, this is a Dutch population of just about 6%. And then you see that the South Asian is about 4%, the African Sudanese is about 9%, the Turkish about 7%. So almost all of them were actually para, except one particular population, which is the Ghanaian population, that have actually been very badly hit about this. So as soon as, of course, you saw this, we were all very worried. So you put a very intensive measures. You contacted the community leaders. You actually managed to talk to the mayor of Amsterdam. So you put a lot of system in place. You talk to physicians, you talk to general practitioners, and you share this with them. And also you went back to the community to communicate this with them so that people can protect themselves. And I think the importance of looking at this type of studies, that by looking into what is happening, you were able to actually to pick up which group is being affected so that you can actually direct the measures to target these people so that every person or within the communities also can be protected from basically being infected by the COVID. So this is some of the findings that is actually coming on. But to come on as well, I think that when you talk about the numbers, sometimes it's very important that you put faces into this. And there is a lot of faces, human faces, behind all the COVID that you talk about. Sometimes we people working in health sector, epidemiology and others, you look at the numbers, but we need to realize that there are phases behind this. So actually this is coming from the UK. And what is interesting also is that even the healthcare workers, it turns out that for the 26 doctors that actually died from the COVID in the UK, 25 out of the 26 were actually from minority background. We also know that about 2/3 of all the NHS staff, National Health Service staff, those people that are working in the health sector, that died from the COVID in the UK were actually also from minority background. So it's not only the minority being affected, but also actually those people that are actually on the front line providing, doctors, nurses, cleaners, and others. They have also been very, very much affected by the coronavirus. So the issue then becomes, why is it that the minority or the migrant populations have been such affected by the COVID-19 compared to the host population? So far, there has been a lot of discussion. I mean, myself and others have written a piece in Lancet about this. And some of the issues that we actually discussed here was that it can actually be grouped into three fundamental or three key themes. And one is actually can be grouped as the fundamental. And the fundamental here can actually include what is so-called the structural racism. Basically, the way the structures within many countries are built up automatically disenfranchised the minorities or the migrant populations. You also have migration factors. When people migrate, usually they come in and they don't have better places to go. And also some of the migration-related lifestyle. And equally also, sometimes there is the issue of equitable resources distribution. Migrants tend to be very poor, or the minority tend to be very poor where they live. And then you also can talk about the societal factors. Again, here that has to deal with migration policies. Even in some countries today, in the very wealthy countries, migrants do not have access to health care. You also have the issue of labor market, the work. Most of the time migrants actually end up doing the so-called essential jobs, cleaning and bikes driving and others. So that means that people are more susceptible, and in most cases actually contracting the virus in multiple times. You also have an issue of living circumstances, the housing. You talk about the idea of actually social distancing is the bigger issue, or the physical distancing. But if you live at a home with multi-generational, families, and if you have a COVID, how can you actually, self-isolating yourself if you don't have a space to do so? And then the issue of healthcare and then the services. Usually if you live in a private area, it's very difficult for you to have access to high quality of care. And then of course, there is also an individual level. And this actually relates to the both, what I've just mentioned before. And that has to deal with, again, poverty, low socioeconomic status. And there is also an issue of religious beliefs, what others refer to as, fatalistic thinking that God will, be there and therefore you just follow what God says. And also more importantly, the medical history, the comorbidities. We know that the minorities tend to have more comorbidities, which I'll be showing you some of the examples later. And also the behavior risk. Sometimes if you are poor and others, you are forced to actually buy the cheap food, not because you don't know that these are healthy, but because you don't have the means to do so. And there is also the issue of genetics, health literacy, and also interpersonal racism. So we think that this might be the potential factors that is actually driving the differences that we see. So if you put up this into a very small jigsaw, I think that you can actually classify it as poverty, crowded housing, poor working circumstances, because if you do cleaning jobs and how are you actually going to have the opportunity to work from home? You have to go to work. and also the essential jobs. If you're a clinician and others, you have no choice, but you have to go to work. And oftentimes working from home is very, very difficult. And I think one of the issues that also needs to be discussed is the migrants without long-term, settled residence. In other words, those that are refugees and others have no resource to public funds at all. And you know that the limited resources actually are provided through the charitable organizations. But for the minority population who are not settled, it's usually very difficult for them to also benefit from some of these organizations, because sometimes people are even afraid to go out. And there is also the issue that I mentioned, the intersection of the risk factor, the chronic conditions. Now you know that the poverty and socioeconomic inequality are closely linked with the comorbidities. For instance, you know that 1 in 5 people are at increased risk of severe COVID, because of the underlying condition. And the chronic conditions, as I mentioned, are actually more prevalent among the migrants and minorities than the host population, certainly in Europe. For instance, in the Netherlands, this is a work that we did a couple of years ago, looking at the rate of stroke, you publish in stroke. And what you see here that, many of the minorities, such as the Surinamese, such as the Antillean populations, such as the Indonesian population, actually have much higher risk of stroke compared to the Dutch population. The same thing applies to diabetes. Again, this is the work that we did looking at the rate of diabetes across Europe. This was basically a meta-analysis. So we've just pulled the data here. This is my team, we did this work. And what we see here that, within Europe, if you are South Asian, actually, you have a nearly 4 times higher odds of getting diabetes compared to the general host population. If you're coming from the sub-Saharan Africa, your risk is nearly 2.6. If you're coming from the Mediterranean and North Africa, again, nearly 2.7. And coming from in the Americas, 1.3. And if you are coming from Western Pacific, your risk is more than 2. So clearly you see here that the migrant populations are very badly hit by diabetes. The same thing also when you talk in terms of chronic kidney disease, which has also been very, significantly linked to COVID. For instance, again, this is the work my team did in Amsterdam. So if you look at the chronic kidney disease, you see that this is the data, just about 3%. But in all the minority groups, starting from South Asians to Moroccan, to Turkish, to all the minority population, the risk is actually higher compared to the host populations. The same thing with hypertension. Again, here, this is the Dutch. So you see that hypertension rate is much higher, particularly among the African origin population. You also know that although people are more aware and they're more treated, unfortunately, the control rate is very, very bad. And that means that, these people become more susceptible in developing the cardiovascular complications. And that also makes them very vulnerable in developing the COVID. And of course, the issue of, depression and others is also very important. People need to go there and to be cheered up during this period. But in this study, you also see that actually, if you look at the migrant population, all of them actually have a higher rate of depressive symptoms compared to the Dutch population. And indeed, when you look at the experience of perceived discrimination, again, if you take it by 100, only 2% of the Dutch says that they've experienced discrimination. But look at what is happening among our minority population in the Netherlands, from Ghanaians to Africans, Surinamese, South Asian, Turkish, almost up to 30% have experienced some form of discrimination. And this can also actually, prevent people from even, accepting the social measures that are being put up there because of lack of distrust. So what are the challenges then for this? I see a lot of challenges ahead. And I think that, first of all, we clearly need to actually identify the underlying factors that some of them have been discussed. And also, how do you communicate effectively in order not to, to end up stigmatizing people? As you know, that during the COVID, particularly in the US, that many people from China origin were being stigmatized because people think that that is where it was coming from. And also in Europe and others, we need to be very careful so that in doing this, you don't see the migrants as those that are spreading it. And again, how do you prevent future disaster in migrants? And I think that actually it makes a whole lot of economic sense in ensuring that the migrant communities actually the risk factors and others are actually prevented. And that also means that we need to confront what I call the elephant in the room. And that means that, ensuring that the structural discrimination is actually being tackled, and also xenophobia and many other factors that actually continue to marginalize sections of people within our societies. And another challenge that I see is actually the uptake of the vaccine by the minority because of actually lack of trust. And indeed, of course, as you all know that, it's been great that now several vaccines have now been developed and in the market, and it shows to be very, very efficacious. I mean, if you look at the Pfizer and the biotech, Moderna, actually up to 95, efficacy. AstraZeneca, 70 and others. So this is being really, really wonderful news. But the thing is that, these wonderful news is also poses a challenge. How do you convince minority population that actually they can benefit from this so that they can actually also take advantage of vaccination? And often we see that there's a tremendous amount of misinformation within the migrant and the minority communities. And that's actually has to do with the fact that many of these people, sometimes because of language difficulties in the country where they live, they tend to rely on their home countries and then the friends. So in the process, they can actually get a multiple information. And that makes it very difficult for people to follow what is going on. And indeed, one of the issues that comes up is that that the vaccines usually takes about 10 years, typically, to develop a vaccine. With the coronavirus, it takes only just 10 months, actually. And those of us, people on this platform, that actually there was no corners cut in designing, testing, and manufacturing it. It was very done because that technology has improved tremendously. You have, microRNA, adenovirus, protein subunit, technology. So, and also with the huge government and private investment. I mean, in many places, there was so much money put into the vaccine that everything could be done very, very rapidly. And also due to new technology, the social media means that there's thousands and thousands of people who actually volunteer for that. So clearly, this has been a wonderful, but at the same time, because of this very quick development of vaccines, this has also created a lot of uncertainties among many people. And for instance, many people think that one of the issues that you have, that people think that can be true, that it can be developed so quickly, and people are apprehensive, or people are not. Often not very welcoming the vaccine. And certainly with all this misinformation going around and others, that can also dissuade many minority population, particularly those groups that have low socioeconomic background, because they give different information. People become more reluctant to accept the vaccine. Meanwhile, they are the people that need it most. And indeed, this evidence of migrants not being receptive to the vaccine is actually becoming increasingly clear. There are several reports in the UK and in the US and elsewhere that, minorities, there is a huge gap in terms of the vaccination uptake among the minorities in the UK and also in the US and elsewhere. So it's becoming a major, major challenge. How do we ensure that the minority that need this most actually get it? And indeed, if you look at the US, some of the data from the US actually clearly show the share of the vaccination among the Black Americans. So clearly, if you look at here, you see that this is the share residents who are Black population. So if you, for instance, if you take this Mississippi, this is the share of the Black population, nearly 38%. But if you look at the share of the vaccine, it's just very, very low. And this is actually goes across all the states in the US. And if you actually calculate it, you clearly see that, the risk ratios, then you see that the risk of not vaccinated is very, very high among the minorities population throughout in the US. And I suspect that you don't have the data in Europe at the moment, but certainly this is the case based on the data from US and then in the UK. So what we're actually doing that the Global Society of Migration, Ethnicity and Health, Race and Health, which are currently chair as the scientific chair, we're actually organizing a meeting on the 25th. So those of you that are actually interested, you're going to discuss this, excuse me. You're going to discuss this on the 25th of March, this month, actually, looking at the COVID vaccination uptake among migrants and minorities. So those of you that are actually interested, you can register for free. And if actually circulated very, very widely. So I'll be chairing this meeting. So please, if you are interested, just ask us and then we can send you the link and then you can register. It's a free of charge. And it's being basically the presentation by colleagues across the globe, including WHO. So I think that, given what we've discussed, what can you do next? I mean, luckily, this is the report from the, ECDC in Europe. And I think one of the issues that we've basically discussed here in terms of looking at the migrants and the refugees is that there is no evidence actually to suggest that the transmission of the virus that causes the COVID is higher among migrants than others. So the only thing is that, it's their social situation that actually prepared them to develop it more so. There is also no evidence that, quarantining people in reception and the detention centers actually prevent the COVID. And another important point is that all principles of physical distancing applied in the communities should also be applied in migrant reception and detention settings. And 4, providing free and equitable prevention, testing, treatment, and care to migrants and refugees in the settings of reception and detention centers. It's critical to all at all times. So clearly, they have come out with this very strong statement. So that means that we need to actually ensure that the migrants and the minorities have equal access. So I think one of the, in concluding, what I would say is that, COVID-19 is killing a lot of people, and the migrants and minorities have been severely affected. So promoting access to healthcare for all migrants and minorities throughout the response to COVID actually needs to be promoted. We need to promote that. You also need to ensure that the lockdown measures do not unduly disadvantage migrants and the minority population further. Remember that all this, lockdown and others, if you are a little bit wealthy or a little bit better off, you'll be able to stay at home, you'll be able to. But if you're a minority and you live in a one room somewhere else, it makes life very, very difficult. And that's why it's so important that we also ensure that these people that have been particularly, in these situations needs to also be taken care of. And more importantly, that means that we need to include migrants in the COVID prevention and their preparedness as well as response, including the vaccination as well into the national plans, actually. And that also means that providing necessary support to migrants and minority communities regarding the prevention measures, for instance, the social distancing. I often say to people that if you are migrant or if you are minority and you live in a very one room, you hire one room somewhere else. And if you get a situation of how are you actually going to social distance yourself? You need to use the kitchen, you need to use that. So it makes it almost impossible. And in some cases, the migrants actually say that they have symptoms. In some cases, they might even be chucked out from the house that they actually rent. So that provides a tremendous amount of stresses to many migrants and minority populations. And I think the governments also need to address the elephant in the room. And that means that structural discrimination, racism, and xenophobia actually needs to be addressed at the national level. So thank you very much for the opportunity to discuss this with you. I think I'll hand over to Professor Aslan. Thank you so much. Thank you.
Dr. Açman, thank you for this excellent presentation. We have been informed about many issues covering all of our questions in our minds. So right now, I would like to give the floor to the questions and comments. But before that, I want to learn brief information about UFA section work. What are you doing in terms of UFA work in migrant populations and COVID-19? Can you just give some brief information on this issue before having the questions and comments?
Absolutely. Thank you so much for this question. I mean, within the UFA section, when they first came in, I actually wrote a document, advisory document. So UFA section have been very, very active. And then the UFA section is also linked with the Global Society of Migration, Ethnicity, and Health. So basically within this platform, we are doing a lot of webinars and seminars to educate ourselves, as well as the policymakers and others. So you have been very, very active within that. And we are also actually now going to plan the coming conference, going to plan a conference specifically to try to address this. And I think the last conference that were meant to take place in Rome, that is not, did not go ahead because of COVID. We actually organized the COVID meeting online. Mm-hmm. And was very highly attended. So the UFA section has been very, very active. So those of us that actually want to get linked to that, you can always contact us so that you can provide information as necessary. We are also working very closely with the WHO Europe in order to develop policies to support the member states in order to address these issues in their own individual countries.
Thank you. Thank you. And as far as I know, Turkish Public Health Specialists Association is also a member of UFA. Yeah. So our colleagues are coming and just participating at the congresses annually. So we are happy that your section is open to the members of the community. So, dear participants, we can have your questions and comments. Soru ve katkılarınızı alabiliriz arkadaşlar. You can directly ask to Dr. Eichmann, and you can have the microphone just for a few minutes. Yes, please. You can, Charles, you can also follow up the chat box.
Yeah.
So there is a question, or I don't know, comment from Alican Korkmaz. He is a young colleague coming from the public health community. Mr. Eichmann, thank you for this insightful presentation on this particular topic. It's clear that social determinants, social determinants of health should be more discussed by health workers. What's your opinion about this comment?
Whether the social determinants of health should be more discussed by health workers. Yeah, absolutely. I mean, I can agree with you more. I think it's very, very important that the social determinants actually need to be discussed. I always say that actually it should be part of the curriculum, actually. So in many countries now, you know, in our country, for instance, we actually now setting up education materials on the migrant and minorities for the health professionals. You know, because the health professionals, every health professional deep down want to help, but they need the support in order to do so. So the support then should come from, I would say, either the institutional level or from institutions just such as yourself, in order to support those people on the floor. So I really agree with you that the social determinants should be number one, actually, in terms of public health and actually clinical medicine, because once we get this information out there, it helps us to be able to prioritize who you are looking for. For instance, if someone comes in front of you, are not only looking at sort of prescription and others, but you're also interested in looking at the situation people live in. If you give a medication to someone else who doesn't understand how to use the medication, they will thank you, doctor, but when they go there, they won't use it according to the way you prescribe them to use it. So it's very, very important that we take the social determinants actually into account in all walks of life. Thank you.
Okay, thank you. And a comment and question coming from Professor İnandı. He also thanks to you for this presentation. And he says that it's clear that migrant population are more vulnerable to the COVID-19, as you have informed us. And could you give some more suggestions on the solutions? Maybe something you want to add?
Yeah, I think that this is again very, very important point, and that's some of the point that I actually try to discuss in terms of the solution. I think first of all, when you look at the issues, often this is actually, that's what I mean by the elephant in the room. The elephant in the room means that the social structures. Sometimes, I mean, in a country like Netherlands, which is a very wealthy country and others, but unfortunately, the distribution of wealth is not the same. So in some cases, you have some of the minority population that end up in the social ladder, you know, the bottom of the social ladder. And that means that many of these people do not benefit equally as the general population. Usually in terms of housing, for instance. Again, this comes to the issue of the social determinants of health. If you want to actually prevent people from social distance, that means that you need to give them the opportunity to have a proper housing. So if people do not have a proper housing, then the whole social distancing becomes a problem. So that means that one, the governments and the civil societies needs to ensure that where people live is, you know, good enough, well ventilated, so that they can actually follow the social distance. Another point I think that you could do as a society is also ensuring that we give the information to the people. I mean, in many countries, the migrant population don't speak the host language. So that means that all the messages that's actually going out don't reach them as they should. So in the end, they end up getting information from their own sources. And so it's not surprising that you see so much misinformation going on within these communities, not because they don't want to, but because they don't know where to get those information from. So that means that, both clinicians as well as policymakers need to ensure that all the measures are actually translated in the various languages, so that the migrant and the minority population can actually get this information like someone else. And another important point I would say is also access to healthcare. We know that many of these people often find it very difficult to navigate through the health systems. So you need to ensure that people, know what to do, and also trust, because if I'm I don't trust the system, even if I know, I won't use it. So you need to build trust so that these people can feel comfortable to go and use the health system that they use. I mean, it's very well known that actually, even in many countries, some of the migrant population before the COVID tend to go to their home countries to seek health care. But now, because of the situation has changed. So that means that many people, even they need it, because of lack of trust, might not. So we need to build trust so that, these people can actually use the care that they can. So, I mean, I can go on I'm talking about the whole evening, but there is a lot that needs to be done in order to address this issue among the minority and the migrant communities.
Thank you. And there are two questions about about the Netherlands organization for the vaccination. Can you give brief information? How is it organized in Netherlands? And another question related with this, if I'm not wrong, to be offered free of charge for the immigrants and refugees in Netherlands. Can you just give some clues or some more information about this organization?
Yeah, I mean the vaccination program in the Netherlands is actually just follow the same rule as the EU because it's a member of the EU. So, as you know, that unfortunately, the whole EU, the layout is not going so fast as you see such as in the UK and then the United States. So you're actually a little bit behind in terms of laying it out. But of course, Netherlands is very, very well organized country. So all the measures are actually being organized from the top. So the system is very well set up. And then more importantly, it's actually free of charge, actually. So all everybody else can actually go and get it. But I think the way it's being done now is that it's not sort of, you can just, wake up in the morning and go. It's actually being done systematically. It was first given to the people on the front line, and then it's now given to the people with the elderly, and now it's come on into, so it's a sort of, if you like, a measures, actually according to those people who are at risk. So if you happen to be a minority and you deem that risk, then you will be vaccinated. But at the moment, that is how it's being done. And you hope that probably in the next couple of months, the speed will pick up very, very quickly. And the vaccination that's actually using is mainly, Pfizer and then Moderna, and also the AstraZeneca vaccine and others. And more recently, the Johnson & Johnson, which I think will be ordered. So this is actually how the system actually is being put up. And so there is a lot of actually centers are now being set up by the municipal authorities so that people can go there and get vaccinated. So that is how the system actually works. And indeed, it's working well, but I think I would say that it has been quite slow, like any other European countries, purely because of, I would say, the bureaucratic way of giving it. Yeah.
Thank you, Dr. Eichmann. So for the last couple of minutes, I would like to have your final comments for the Turkish public health specialist community. Mm-hmm. Can you give some more information or some more suggestions for us? What are your insights for the future?
Yeah, I think what I would say is that the Public Health Association of Turkish play a very, very important role. I mean, many of you are actually in the forefront. Turkish is a relatively wealthy country, and you have your own minorities population within your own countries. You also have many challenges. You have a lot of migrants from Syria and others. So some of these issues that you're actually discussing is not new. You face it on a daily basis. The issue is, how do you ensure that you get the resources and the know-how to be able to provide the services to these communities, usually because of a language or because of, you know, mistrust and others. So all the issues that are actually touched on is equally facing many people within this platform. Mm-hmm. So what I would say is that, you know, there is always a help. WHO, you know, Europe, there is a lot of information up there. And also what I would say is that, you know, those of you that need information and others, we have actually now beginning to map all the relevant information that is needed on how to actually support these migrants on the global society website of migration ethnicity website. So you can always go there and get it. Furthermore, those of you that are actually interested in this topic as well, please feel free to contact us. If there is a need be, so that we can all work together. This is not only one country doing, one country cannot do it. Mm-hmm. You know, so we need all institutions such as yours to come on board, actually at a European level, so that we can all work together to address the health needs of these people. And more importantly, I mean, I keep on saying that, you know, migrants, whether you like it or not, are increasing. And also, actually, it's always been the case. I mean, a country like Turkey, who has been one of the most oldest and most, you know, country on earth and in terms of everything. I think that when you talk about migration, this has been a long history of that in Turkey. So actually, I don't have anything to say more than what you know already about this topic. But I think what I would say is that, you know, we all need to come together and face it, because whether you like it or not, of course, there can always be a lot of politics around it. But the issue is that if you are a healthcare worker, if you are a frontline worker, and if you see someone else needing help, the politics is very, very far away. Your immediate, you know, need is, how do you help these people, as you've been trained to do? So in that regard, it means that you also need to be ready. And being ready means that you need the support from the institutions that is around you. So please make use of that. And also, I would say that actually, I would be like very much if you know, Turkish Public Health Association work very closely with the European Public Health Association, the Migrant Health section. And then probably you can even do some work, you know, joint work together during the European meetings and others. I think that I can easily actually discuss it with colleagues, and we can build more collaboration, and then you can learn from each other. You know, there's a lot you can learn from your side, and there's a lot you can also learn from our side. So that it becomes win-win. Mm-hmm. So I think that is what I would say. And for on the personal level, within the Netherlands, we are doing a lot of work among the Turkish migrants here in the Netherlands. And I think there is opportunity also to build it up, because actually, I would say that, you know, we can learn a lot from what is happening in Turkey by doing, for instance, a comparative analysis. The knowledge can be used to help the Turkish migrant here, and then the vice versa. I've done many of this work in many African countries where you compare the migrants to the host countries. Mm-hmm. And usually also bring opportunities in terms of research and also in terms of, you know, collaboration between institutions. So I think that there is also opportunity for us to explore this further. And I'll be more than happy to explore this further with those of you that are interested in the topic. Thank you.
Thank you. Really, we thank you once again for this excellent presentation and for this excellent, for your comments. So I'm sure that each participant here is open to any collaboration with any person from the globe, coming from the globe. And we, as far as I know, Turkish Public Health Specialist Association also has a section of working on migrants. Okay. So I'm sure that we have participants from those groups. Yeah. So I'm sure that they will have opportunity to collaborate with you at the institutional level as well. So it's time for closing. I thank you once more on behalf of the society. Çok teşekkür ediyorum bütün katılımcılarımıza. And I give the floor to Dr. Lütfi to conclude. Thank you for all.
Thank you very much for your nice presentation. We are happy to listen to you. Thank you very much again. Alp Hocam, siz de eşlik eder misiniz bize? Birlikte teşekkür edelim arkadaşlar. Dilek Hocama ve çok değerli konuşmacımıza teşekkür ediyorum. Çok keyifli, güzel bir oturum oldu. Tekrar aramızda görmek dileğiyle EPA'yı, yani çok mutlu oldum. Çok güzel bir webinar oldu. Alp Hocam, ekleyeceğiniz bir şey olur mu? Ya da hocalarımın katkısı.
Hayır. Çok teşekkür ediyorum. Profesör Eggman Young'a da çok teşekkürler. Thanks a lot for really nice presentation. Dilek, sana da çok teşekkür ederiz. İyi akşamlar. Have a good night.
İyi akşamlar.
Hope to meet you again.
Çok teşekkürler. Tekrar görüşmek üzere.
Thank you.